Welcome to the ISMP Medication Safety Podcast supported by Novartis, Name Creation and Regulatory Strategy. My name is Endanita Haizerai, PharmD, and I am a Regulatory Pharmaceutical Fellow in Medication Safety for Novartis, Name Creation and Regulatory Strategy. Today we are speaking to Kelly McEwen, who is a labor and delivery nurse in the greater Philadelphia area. Kelly received her Bachelor's of Science in Nursing from the University of Pittsburgh and has been working in the labor and delivery setting for the past 6.5 years. She is currently a student in Villanova University's Master of Nursing Education program, where she has been provided the opportunity to complete her final clinical practicum with ISMP. As a labor and delivery nurse, Kelly administers Oxytocin to her patients on a daily basis. For those listeners who may not know, what is oxytocin and what is it used for in obstetric care?
Hi, Antonina. Thank you so much for having me. So oxytocin is a natural hormone that's found in the body, and it plays a really big role in labor and the postpartum period. So it stimulates contractions, it stimulates lactation, and also promotes maternal and neonatal bonding. Pitocin is the synthetic form of oxytocin that's administered intravenously for multiple different indications during the time of delivery. So IV oxytocin is used in the intrapartum period in very small, precise doses, and this is used to induce or to augment labor, and it can also be used as an adjunct in the management of an elective or incomplete or inevitable abortion. And then during the postpartum period, IV oxytocin is administered in very large doses, and this is given to really contract the uterus during the expulsion of the placenta to control bleeding, and this is used as a means to both prevent and treat a postpartum hemorrhage.
So let me understand. A single patient may receive oxytocin for both these indications during different phases of labor. Can you expand on this?
Yeah, definitely. So oxytocin is used for induction for a variety of different reasons. So somebody might be induced for a medical reason. They might have an elective induction at term. There's also post-term inductions. So most providers will encourage or recommend an induction of labor if the patient hasn't gone into labor on their own by 42 weeks. And then it's also the standard of care to give oxytocin in the postpartum period. So many obstetrical organizations, such as the American College of Obstetricians and Gynecologists, the Association of Women's Health, Obstetric, and Neonatal Nurses, and the American College of Nurse Midwives, they all support the active management of the third stage of labor. So that is to prophylactically give oxytocin to every single patient after they deliver, even in the absence of risk factors. So for an induction, the most common concentration that we see is 30 units in 500 mLs of usually lactated ringers. And it's really helpful to have this concentration because the rate is expressed for an induction in milliunits per minute. So this allows for a really simple conversion rate of 1 milliunit per minute is equivalent to 1 milliliter per hour. So typically an order would probably look something like to initiate the oxytocin at 0.5 to 2 milliunits per minute and then increase by 1 to 2 milliunits per minute about every 15 to 40 minutes. However, some physicians do use higher doses of induction oxytocin, and this is supported by organizations like the American College of Obstetricians and Gynecologists. This order might look something like 6 milliunits per minute and then increase by 6 every 15 to 40 minutes. So the Pitocin is titrated up until an effective labor pattern is established, but it also is discontinued or decreased in times of fetal distress or excessive uterine activity. And as for postpartum oxytocin, many facilities use that same 30 units and 500 mLs concentration, but it's also common for different facilities to use different concentrations for postpartum oxytocin, such as 20 units in 1,000 milliliters or 40 units in 1,000 milliliters. And the rate expressions for postpartum oxytocin are typically going to be units per hour, so different than induction oxytocin. A typical order for postpartum oxytocin might look something like bolus 5 to 20 units over 30 minutes, and then administer a maintenance dose of about 5 units an hour for about 4 hours. So whatever the concentration is, it's just always important that the nurse administers the oxytocin using a smart pump with dose error reduction safety limits.
So it seems as if this variation in use and differences in rate of administration can create possible safety challenges. Is this true? And if so, can you tell us about those risks?
Yeah, so there are definitely risks that come along with the administration of oxytocin. So I would say that the biggest risk is probably inadvertently administering a higher dose than that is prescribed for during an induction. So whether this is from an accidental bolus of medication, nurses are often giving fluid boluses to laboring patients, or if it is from an accidental rate of a postpartum Pitocin order. So these situations could cause hyperstimulation of the uterus, which could cause fetal distress, the need for an emergency C-section, or uterine rupture. And there have been maternal, fetal, and neonatal deaths that have occurred due to oxytocin errors like this. So because of the different indications and the different dose rates, we see a variety of ways that oxytocin is used in the drug pump libraries as well. So ideally, smart pump libraries should have different profiles for the induction oxytocin and the postpartum oxytocin with different safety limits. And the bolus function or the secondary function should never be present in an induction oxytocin medication profile. There should also be appropriate drug limits that exist so that a higher rate than that was intended could not be entered into the pump. So for example, if a nurse were to enter a rate of 14, the pump shouldn't allow her to accidentally maybe select 144, as that would be a really dangerous rate for a laboring patient to get. And as for the postpartum oxytocin profile, there should be an option for a bolus dose with associated dose limits. The library should be easy to navigate, and then nurses should also be thoroughly trained on the use of the drug libraries too. If this isn't the case, then nurses will be more likely to use something like the basic infusion mode, which would definitely increase the likelihood of errors.
What other safety recommendations do you have for healthcare providers caring for perinatal patients to limit the risk with this drug?
Yeah, so per ISMP best practice recommendations, there are several strategies that can be used to reduce errors with oxytocin. So the first one would be to use standard order sets for the intrapartum phase and the postpartum phase, and to standardize to a single concentration bag. So for example, this might be the 30 units in 500 milliliters. It's also a good idea to choose standards for how oxytocin doses are expressed and how the rates are expressed. So this might be different from an induction compared to a postpartum rate. For example, we talked about the milliunits per minute and the units per hour. Whichever one is chosen per indication, that should just be a standard across the board. And the nurse should avoid bringing the oxytocin into the room until it's actually necessary. The oxytocin should be pre-mixed, either in a commercial pharmacy or the pharmacy in the hospital, and it also should be boldly labeled on both sides. And then it also would be good for nurses to perform independent double checks for induction oxytocin, and for them to understand what that double check entails. So it should include verification of the rate, the patient, checking the lines, and making sure that the smart pump matches the order in the electronic health record.
Thank you so much, Kelly, for sharing this important information with us today. If you would like more information about ISMP or information regarding errors associated with oxytocin, please visit ISMP's website at the addresses displayed on the screen. If you have any further questions, please email ISMP at info@ismp.org. This now concludes our podcast. Thank you.